Hello, this is Dr. Nancy Trimbley with your Healthcare Arsenal podcast. This podcast is designed for that person who knows there's a better way towards wellness. They just don't know what that better way is. And my hope for you is that with each passing episode, you get closer to being your own best expert. So today we have Dr. Ashley Weiner and Dr. Alli Amt of Pelvic Affinity, which is in Crown Point, Indiana. So welcome, Dr. Ashley and Dr. Alli. How are you
Thank
today?
you so much for having us.
Yes, we really appreciate the invite.
You're welcome. We kind of stumbled upon each other recently because for years and years, I had been referring any kind of pelvic floor work or what I perceived to be a pelvic floor problem to a local physical therapist. And she would hop around, so I'd have to like find her and like, where is she now? And I was in one of these circumstances with a patient, and she said, I found these doctors. What do you think? Can you check them out?" So I'm like, "Huh, sure." Well, I brought up your website. I'm like, I like these women. I like them. I
Oh,
think
thank
they're awesome.
you.
Yes. And what I got from your website is like, let's not make this so complicated. Let's make this light. You're gonna be fine. Come
Right.
see us. We're your besties, and we're all
Yep,
gonna be good.
that is definitely the vibes here.
So,
Yes.
so tell me, how do you explain pelvic floor work to somebody that has no idea what it is?
I like to start off that we are pelvic floor physical therapists that treat anything that deals with pee, poop, sex, pain, prolapse dysfunction in males and females. Because everyone understands what peeing, pooping, sex. Once we say incontinence, defecation mechanics, they're like, what? So I like to
Keep it simple.
keep it simple, keep it lighthearted, and have an open conversation of like what is going on with their symptoms. So anything that literally deals with pee, poop, sex, pain, prolapse.
We also see a lot of like complicated hip, like that hasn't resolved with regular physical therapy, and maybe another physical therapist or a chiropractor is thinking that something may be related to internal muscles. We get a lot of those people as well. So it may not be a true pelvic floor diagnosis, but another provider is thinking that something is going on with the pelvic floor.
Yeah, like the muscles of the hip, when you really look at a diagram of it, it's just like this kind of like this webbing of these tiny muscles. It's such a complex joint and they all
Oh, yeah.
connect deeply in the pelvis. So that really makes sense to me.
A
Mhm.
lot of your deep hip rotators are in the pelvis, piriformis, obturator internus. So some of those deeper, hip rotators are easily assessed with an internal evaluation, whether it's
Wow.
vaginal or rectal.
Wow. Totally makes sense to me knowing the anatomy. So let's get back to regular people now. So tell me about like your favorite client or patient that comes in. What is your one of your favorites look like?
Ooh, we might have a little, I think we're very similar, but we might have a little different. I love birth prep. That would probably be one of my favorites. So we've been getting a lot of pregnancy patients that are really nothing is quote unquote wrong with them, but they want to learn how to push properly. They want to make sure the perineum is moving appropriately. They want to maintain strength throughout their pregnancy, concerns with diastasis. So that's probably one of my tops. But I also love dyspareunia, which
I
is
was
pain
just
with
gonna
sex.
say
That's
that.
probably my top.
That's mine. I love pain with sex, treating pain with sex.
Wow. That is an awesome topic. So tell us
Mhm.
more. I mean, it's
Yeah, so we get a lot of referrals for all age
All
groups really.
ages, virgins, postmenopausal, 19, 20, all the way up to 60s.
Hmm.
So it's really like the whole lifespan of a person, and they may develop pain with sex, dyspareunia, because life factors, hysterectomy, hormone, whatever the case may be.
Stress level.
Yeah.
That's another one that can really impact through the lifespan. But yeah, they'll give us a call and they'll say some complaints. I've noticed some changes. I've been kind of avoiding intercourse a little bit because it's hurting. And, sometimes physicians aren't really understanding the root, and topicals aren't working, lube isn't working, relaxing isn't working. So there's something going on with the deeper muscles that we need to figure out, and that's what we do.
Yeah.
Yes. And it must be so hard for somebody to acknowledge that and think, oh, it's not like a passing phase, or it's something, because that one of the things I talk about in Undercover Vitality, the community, is connection with others and finding your joy. And we as humans, sex is a way that we express our joy and make those deep connections with our partners. So this is really crucial for human happiness.
Super. And
It is.
if we can make a change in somebody's quality of life, that is so rewarding to us. And I think that's why we like that diagnosis so
Oh,
much.
yes. They're able to do multiple positions. They're not fearful with it. They're able to enjoy it now. It's really life-changing. And it's very intimate work with us when we're treating the patients, and we just get to know our patients like in a different level, and they're so appreciative, and it's a safe place for patients.
Absolutely. So what is a typical first visit with, a brand new person that you don't know? What does that entail?
So we work one-on-one 60-minute treatment sessions, and our evaluation is also 60 minutes. And we like to think that the pelvic floor doesn't become dysfunctional on its own. There are things up the chain or down the chain that is creating the dysfunction of the pelvic floor. So
What do
we
you
like
mean?
like rib mobility, breathing
Spine.
mechanics, spine,
Feet.
core, glute, hip, the way you're positioning yourself and standing, sitting. We look at it all. If we just did an internal, that's really, if we just do internal work, that's a symptom. The root cause is, how are you positioning yourself in the car? How are you cleaning the house?
How are you lifting? How are you squatting?
How
All
are
of
you
that.
doing your exercises when you're going to Orange Theory, F45, CrossFit? How are you lifting baby? How are the ribs moving, the thoracic cage moving when you're breathing? It's really, we look at whole person.
And we're really big on reassessing frequently. So we'll apply one intervention and kind of reassess what the pelvic floor is doing. How is it responding to this change in pressure? How does it respond to your position change? So we're really keen on doing a reassessment
And
pretty much every visit.
correct. And assessing just not on your back. Assessing
yeah.
on hands and knees, assessing and standing, assessing in a squat. How are you bearing down to poop? Are you even doing that correctly? People have hemorrhoids. Well, if you have a lot of tightness and you're straining, you're causing hemorrhoids. So we do a full body assessment. And we do an internal glove, lubricant, no medical equipment, no speculum, no stirrups.
God.
We are assessing, we are muscle experts. So that is what we're good at, muscle experts. I don't know what's going on with the ovary.
Right.
Why
We're
check
not
that?
looking at, cervical health. We're not doing, a pap smear.
No.
We're just looking at the muscles. So there's no tools involved. Some people have a little bit of fear around that, especially if they've had a bad history of a bad exam. So we like to just reassure people there's no tools, nothing's going in there besides just a gloved finger with lubricant.
Right. And that, when you were talking, I'm thinking to myself, this is why we are like have this affinity, you and I, because that's how I look at people. They come in with their lower back, and I'm like, well, we got to look at your hip, we got to look at your neck, we got to
Mm-hmm.
look at your pelvis, we have to look at, yeah, what are you wearing on your feet? So we have
Mm-hmm.
to look at all of those things to address the manifestation of the
Mm-hmm.
problem. Yeah, the
Mm-hmm.
symptom
Absolutely.
presenting isn't like, we're not going to tunnel vision just look at that. We have to look at the whole person.
Yep.
Mm-hmm.
Yup. Very cool.
Yeah.
So tell me more about that first visit with somebody so the people, our audience, can say, okay, I know what's going to happen when I walk in
Yeah.
the door there.
So once we go through like a thorough screening of the whole body, internal exam, as long as there's consent, we will go over all of our findings. So we're really big on making sure that we're speaking clearly, educating patients, because this is a new concept to so many people, even in the medical field. We've treated so many medical providers that,
Gynecologists
yeah,
I've treated.
it's like,
Yeah.
wait, I didn't even really know that was a thing. So just educating on the anatomy, educating on why this is happening, making sure they understand our findings and what our goals would be for them. And we also want to go over what their goals are for themselves.
Mm-hmm.
And then we always give them something to get started with for a home program as well, just to kind of get the ball rolling on things.
Mm-hmm. And we ask a lot of questions. We're very subjective in understanding what their issues and concerns are. We listen to them, what their goals are, and then we, do our assessment after that. We have a model. We show them the model before we do any type of internal, and then we kind of go from there.
Mm-hmm.
Wow, that's awesome. So when you set up a treatment plan, so they have homework to do, so they have
Mm-hmm.
exercises. And how often will you see them in your office?
Usually it's one time a week, I would say, for average, varying from like 6 to 12 to 14 visits, just depending on what is going on. So if it's a, new postpartum mom with very minimal complications, sometimes that's, 6 visits. If it's a chronic pudendal neuralgia, a chronic pelvic pain, that's going to take a little bit longer. And sometimes people are on kind of like a maintenance through the year.
Sure, that makes sense to me. It's similar in chiropractic is that, if there's been a very long-standing problem or there's degeneration of the spine or then they're probably going to need some maintenance.
Yeah.
Yeah, so tell me more. Tell me about like a mystery case that you had that you're like, wait a minute, what's going on?
We get patients that open up and talk about like clitoral discomfort.
Really?
And yes, and that's actually could be a branch off of your pudendal nerve. And so doing a lot of rectal work, actually, it will
We have seen
subside
that
the
worked.
clitoral. So it's not, even though someone's like, no, it's right here, clitoral, we like to go to the spine and follow the track of the pudendal nerve and treat the muscles from a lot of rectal stuff, actually.
Yeah. And we see a lot of male patients, young male patients.
Yes.
I've been noticing a trend lately, and I after 7.5 years of doing this now, I'm like, baseball players and golfers, and they will suffer in silence. They have growing pain, they have scrotal pain, they have tip of the penis pain. Feels like they're getting kicked down there 10 times a day. There are things that these men are explaining that have been going on for years. And I'm like, golfers and baseball players, and we have to look at their rotation because it's coming from repetitive rotation.
And a lot of our young guys will be blamed, oh, you have prostatitis, given antibiotic. And it's like really the worst thing to hear because it's like, oh, you don't have prostatitis. It's actually the pelvic floor musculature system mimicking
an infection.
It's almost like females that have a UTI feeling, but there's no UTI. It's the same in males. So are they complex? I feel like we know what to do with them now, so they're not complex to us. But when we first started in pelvic health, I'm like, what? Am I what?
Yeah.
And then you get trained, and then
Yeah.
you go through all the
And
things,
then
and
you
then
see
it's like,
trends over and over
Yep.
again, and it's like, oh, I've seen this a million times now.
yes.
So, and it's great to have someone with like us together is been a godsend, honestly, because we constantly are bouncing ideas off of each other. We've been doing this for the same amount of time.
We
So
think very similarly. We're both very hands-on. We don't feel a taboo of like, oh, should we do rectal on hands and knees? I don't know. And it's like, no, that's how you weight bear the muscles.
Yeah.
And then you're seeing what the muscles are doing and seeing if some muscles are showing up more than other muscles. Maybe the outside muscles aren't kicking on. So then the pelvic floor is like, okay, I guess I'll do all the work now.
Mhm.
And then they're creating pain and compression against the nervous system.
Wow, that's like fascinating. That's so
We love
I
it.
had no idea.
Yes.
Wow.
No.
That's why we love it. It's so cool. It's cool to
Yeah.
make change too.
So, I know you guys have only been in your current location for what, 6 months, is it?
A year.
A year.
Mhm.
A year now.
Okay,
We've been
congratulations.
practicing longer
Long
than that.
time.
Mhm.
So then how do you get the word out? How do you, is it just like,
We get a lot of like, so we treat one patient and then she sends her mom and then the mom sends the husband and the husband sends the uncle. So we get a lot of like that. And then we also get a lot of traction on social media. Same thing. We've kind of made our social media lighthearted and kind of funny. So people aren't afraid to call because
yeah, it's word of mouth. It's a lot of word of mouth. Like, oh, I went to a hairstylist and the hairstylist knew a girl who came to here. I'm like, what? Like
hairstylists are great. I mean, that's
Yes.
nothing to do but talk while they cut people's hair.
Yes, I think it's more word of mouth because we don't really have any ads or
nothing really like that. Another thing too, we have both the same feelings. Chiropractors refer to us all the time. And there has always been this big like friction between PTs and chiropractors, which I don't understand. Like we should be best friends.
Right, exactly.
In the pelvic floor world, it works so well because we don't manipulate people. We don't know how to do that. But if you're manipulating someone and it's like, why are they coming back week to week and it's not holding, or it's, something keeps pulling them back. A lot of times it's the pelvic floor just based on the attachment points. So if you get one side pulling and one side not, you're going to get that shearing force on the SI joint.
Totally makes sense.
And I would say like majority of our patients are seeking chiropractic care and a musculoskeletal person.
Wonderful.
I think they do phenomenal when they have both components because like Alli said, we do not manipulate. We don't do any grade, any type of manipulation with the spine.
I have a theory about the chiropractor. Well, I think I love physical therapists because they help me do what I can't do at my office. I'm just not trained in a lot of that stuff. I always boil it down to billing codes. A lot of chiropractors use the same billing codes as physical therapists. So like, don't see the chiropractor because
we'll eat up your
and I think it's just billing codes.
Oh, and that's just sad that it came down to that because we just had so much success with treating the whole person as a team. And we refer back to chiropractic all the time. Like, this looks like something that maybe needs to get adjusted or something like that.
People ask for recommendations for chiropractors all the time.
Well, cool. I mean, we get like 99% of our new patients from either other health practitioners that we know or our patients. But it brings up another thought for me. As a chiropractor, we have massage therapists in the office. We do myofascial release. We do cranial sacral because if there's restrictions in the muscular system and they're going to keep pulling things out of alignment. But why I never thought of the obturator, which attaches the hip to the sacral apex, right? Is that what that version? So of course, if that's tight, it's going to keep pulling the sacrum over to the side. Duh! Like why I never thought of that.
Yep.
That it
Coccygeus
makes
is a big one too,
Yeah.
with tailbone
Mhm.
pain or like SI joint pain. Sometimes it's from coccygeus, and you
Mhm.
can't get there unless you do an internal exam, really.
And the piriformis attaches to like the
oh,
front of the sacrum too. So even
yep.
getting up rectally a little bit deeper and then working on the piriformis that way is also like super beneficial with our patients too.
Yes, absolutely. It totally makes sense to me. All right,
Mm-hmm.
cool.
Mhm.
I'll put you on. I mean, you're definitely going to be on my favorites list that I keep track of.
Aw, well, thank
Oh,
you.
absolutely.
You're on
What do you
ours
mean?
too.
Yeah.
Cool. Let's see. So, what are some misconceptions people come in with when they talk to you either in the office or outside the office?
Yeah.
All we're gonna do are Kegels, right? I've been doing my
That's right.
Kegels. I'm leaking pee all over, but
But
I'm
it's
doing
not
my
working.
Kegels, but it's not working.
Yeah.
Oh, we wouldn't
Uh,
be so busy if all we did was Kegels.
yep. Yep.
We wouldn't be a profession
No.
if that was the case.
Rarely does anyone need Kegels in isolation. I could think of probably one good situation, and that's someone that has had a prostate removal. Sometimes they do just need repetition and volume with Kegels. Like sometimes that works. But I would say a majority of our people don't need Kegels in isolation. Either that or they're doing it completely wrong or they're high tone.
Yes, or their coordination is completely backwards
There could
with
be
their
that.
breath.
Yep. So
Yes.
that's a big misconception.
That an internal is going to be painful, and we're
Mhm.
very gentle with the internal. We go where your body allows us to go. We don't go past. That is counterintuitive of what we're trying to achieve. Because if we're causing pain, then someone's tensing, and then we don't get the accurate strength of the pelvic floor and how the muscles are moving. So internal should not be painful. And if it's a little uncomfortable, that's why you're here.
Yep.
Right.
Another
Right.
one maybe is that you're going to be like in a big gym area. A lot of people have gone to physical therapy for something else, like a knee, and they're in with a bunch, like 3 people at a time on the bike. And our clinic is very small. You're in a private treatment room 99% of the time, most times. We do have like a little exercise space too, but it's always one-on-one with us. Like you're never just given a sheet of paper to do exercises by yourself.
Right.
Yes.
Right. Yeah. Not cookie cutter at all. Not at
No.
all. Yeah.
And when people ask, oh, what exercises should I do for this, like friends or family? I'm like, I literally have no idea without assessing you. I don't know if you're a strength person or you're a down training, dampening person. I don't know how strong your hips are or how you're utilizing your core. So we really don't give out exercises unless someone is thoroughly assessed because everyone is so different.
Yep.
It's not cookie cutter. How we treat Susie is different than how we treat Ben and different than Sarah. It's like really how the body is presenting to us.
Absolutely. And I've had other physical therapists on the podcast, um, and I talk about that with my patients. Like sometimes physical therapy is cookie cutter. They look at the prescription on the piece of paper that they got from the medical doctor, and they're treating the prescription.
I know.
They're treating the diagnosis. It doesn't matter if you feel better or not. They're going to treat this diagnosis. That's all they're going to do, and it breaks my heart. It's so sad people put in time and energy into that. So and every person is different. And you'll find that with chiropractic too. Some chiropractors, you're going to get the same thing every time you go. And that's not how I work because everybody's so individual. And every day you see them, they're going to be different because you worked on them before. They lived their life. Just like you guys say, you evaluate almost every time because
Oh yeah.
And a lot of times we can tell like what's going on this week. Are you a little stressed or what's going on? Oh, I had to take my kids. My kids are sick, and it's like, your pelvic floor is telling us that.
Wow. So, is there any like general things you should do just for pelvic floor health?
Probably exhale with a lift.
Exhaling with a lift. So if you're like lifting stuff off the ground for pressure management would be just an easy thing that you
Easy.
Everyone should be doing that.
Blow before you go. You're going to pick up your water case, exhale as you're lifting.
Yep. Hydration. I would say that, working on reducing bladder irritants.
Sit your butt cheeks on the toilet seat when you're peeing. Do not hover.
Oh.
Those are some general ones.
Oh, sip on your fluid. Do not chug your fluid. Don't look at it as 6 p.m. Oh, shoot, I should get on my fluid intake right now.
Mm-hmm. Big one with males, don't push to pee. So a lot of people like push down like they're having a bowel movement, and no, don't do that. You want to relax and let that flow on its own as best you can.
If you're sitting on the toilet and you haven't pooped within 5 minutes, go somewhere else.
Just get up.
Go for a walk. Get up.
Address it later. Oh, and that's another good one too, is on your first urge, if you can go to the bathroom, bowel movement, on your first urge, go.
Yes, respond to it within 10 minutes of feeling an urge to poop. You can actually create constipation if you don't respond to the urge.
Totally agree.
We can go on and on.
So those are our general, we tell everybody.
You should put those on the back of a t-shirt.
I know.
Like a checklist.
Yes.
That is so cool. Let's see. What else can you tell me? Tell me about postpartum and what you can do for that, or tell me about pregnancy health and then postpartum.
I feel like there's a misconception of, go to PT after baby. We treat a lot during pregnancy. It is life-changing for their birth story. It's life-changing for like just their pregnancy, their every day-to-day life. I really like treating pregnancy.
It's cool to see progression to, like, if we see someone from second trimester all the way through, then we see them postpartum. It's like really cool that we get to see that.
They're not coming and limping with pain. They're able to work until their due date. They're able to continue on with their Orange Theory. They're able to continue on with intimacy. It's almost like the quality of life during pregnancy is like so much like better with pelvic floor therapy and chiropractic care.
Yes.
And we do a lot of internal stuff during pregnancy as well. If they're cleared by their provider, they're good to go. They're not in their first trimester. They're not on pelvic rest. If they're having sex, our little finger is not going to do anything compared to any type of penetration.
No, we're not doing anything close to the cervix. We're way lower than that. So it's definitely not contraindicated. As long as they're not on pelvic rest, you're fine. And it makes a huge difference. And that would be something that I would say has changed over the last 5 years. Because they used to be very in the pelvic health space. It used to be very like
don't touch them.
No, don't do. And it's like, these people are cycling 20 miles a day. Like, they're okay. Like, we need to address.
We're still getting that now. Like, they do internal on pregnancy. We hear through the grapevine. It's like, what? Why? We're pelvic floor therapists. Isn't that our job?
That's what we're trained to do. And it's like we're screening them to make sure they're good candidates for it. We would never do it on someone that would be
on pelvic
high risk
or
no. So it's very indicated for people, and it's so helpful. I mean, tailbone pain. I recently had someone, she had terrible tailbone pain with her first all the way through, and nobody could really figure it out. So it started happening again with her second, and she found us, and I did a ton of rectal in different positions. Boom, gone. It's like 30 weeks, it's gone. So that was really, really rewarding.
And we get a lot of messages through our patients about their birth story. I mean, we get text messages a lot like, I didn't rip, I pushed baby out in 2 times. The providers were like, where'd you learn to push? You're pushing so well. I mean, that alone is like,
yeah. We're always sending them back and forth to each other, like, yes. Especially if it's someone who's had a little bit of trauma the first go around. Someone that pushed for a long time and had a grade 3-4 tear, like terrible birth experience, and then they're like, that ain't happening again. I'm going to control every element that I can. I know that nothing goes perfectly according to plan, but I'm going to control the things that I can. And those people do great.
Yes. I love how we also focus on the moms.
Mm-hmm.
The moms get like lose sight because everyone's so focused on baby, and I love focusing on, well, what a mom brought baby to life and brought baby here, and I want to take care of the moms too. They're having their issues. I just like focusing on mom as well.
Absolutely. And it goes back to that connection with the human connection and joy, and having a beautiful birth experience, I think, is so important. And our environment has kind of destroyed our bodies, and the conventional medical model has taken us away from this beautiful birth experience to something that should be it's like an intervention. It's a diagnosis, so we need to treat the diagnosis. So it's exciting to hear you guys talk about that, getting the mom ready for this beautiful experience as much as we can.
Yep, exactly. We have people that want to go for a VBAC. So as long as they're cleared by their provider, let's work on the pelvic floor. Maybe that was a blocker your first time go around. If it's too tight, that's sitting right in the mid pelvis.
You're not pushing correctly.
So the baby could get stuck. We teach different pelvic openers for different levels of the pelvis during labor so that they're prepared to be able to move around. So we just want to give them all the tools to be successful and hopefully have the birth that they want, because that stays with you for a long, long time.
It starts the connection. Yeah, I totally agree. Now, I do a specific breech turning technique called Webster breech turning technique, where we adjust the lower spine, sacrum, pelvis, and then do abdominal and round ligament work. I bet you have breech babies turn on their own as you're working on the moms, right?
Sometimes.
Yeah, so if you ever have any trouble with that, with a breech, just send them over and I'll get all their stuff done.
Yes,
definitely.
So what else? Tell me one more cool story and then we'll wrap up.
Do you want a patient story or do you want an us story?
You do. I don't know. What do you want?
What?
Oh, man.
Well, tell me this. Let's see. Alli, what got you into this specific line of physical therapy?
I think it found me, to be honest. I didn't know what it was, just like many, many people. I thought I was going to do sports ortho, which now I'm like, what was I thinking?
An elbow? That's boring.
Yeah.
I want to talk about sex.
Yeah.
I don't want to talk about no elbow, no knee.
What's a meniscus? I have no idea.
Yeah.
So my first internship, my clinical instructor was a pelvic floor therapist. She did 50-50 pelvic floor and orthopedics. And she's like, Alli, you'd be really, really good at this. Like, just look into it, see if you're interested. And so from there, I was like, I'm going to look into it. And I was always really, really good at the genitourinary system, bowel bladder, in PT school, and everyone else was like, why are you good at this? And I'm like, they're all struggling. They're like, what's a ureter? And I'm like, I was just really, really naturally good at it. So it kind of found me.
It was love at first sight. It was a personality bonding, I would say, for me. It's a personality thing. I never had pelvic floor dysfunction. I wanted to do geriatrics in a nursing home. That's what I wanted to do.
That's a calling.
I know. And then I saw something online about women's health PT, and I went to like a seminar during my first year of PT school just to check it out. And then I remember walking in the room and I saw like dilators and vaginas and like dildos, and I'm like, oh my God, this is amazing. Wow. And I remember I got teary-eyed. I saw a dildo and I got teary-eyed. And I thought, this is my calling. This is what I was meant to do. And so I think on a personality standpoint, I want to know more about all of this type of stuff. It's a level of interest in me.
Yep.
That's just what it is.
Oh,
I want to
totally
know more. It doesn't feel like work. I want to be like, what?
Yeah.
I want to know more.
Or like the weird stuff. It's like, nobody else is looking at this. Let's
look
at
like fecal incontinence. Like, you're pooping your pants. What?
Let me try to see if I can fix it.
Yes. Yes.
Yes. I love it. I love it. You guys are so fun. And I really, really enjoyed this conversation. Now I have one final question, and I didn't preview this to you. And you'll have to answer each individually, not as a team on this one.
Okay.
If you had a billboard for all to see, what would it say?
If you're in trouble, call Pelvic Affinity.
That's awesome.
That's
Best answer ever.
I love that one.
That's on our website.
Yes, it's on our website.
It's on our website.
Ooh. Maybe mine would be a little deeper. I think that mine would say, like, find your authentic self, because I feel like when people are finding their authentic self, you know, the light bulbs are going off. They look different. They start to have this glow about them. So I want more people to just be true to who they are. And I feel like even in the last year of working with Ashley, and we've talked about this many times, that we're just finally able to be like, this is us. Like, we want to do it this way. We're going to do it this way.
Like, even our social media, our Instagram, we post like funny stuff. And I feel like, no, this is actually who we are. We're professional in the room, and we know how to read the room and guide the room. But outside the room, I'm lighthearted. I want to laugh. Mm-hmm. You know that. Yes. We laugh every single day. And if we're not laughing, something's wrong.
Yes.
I don't know. We're just like kind of fun-hearted people. We don't take things like super, super serious, and it's really all about how you perceive things. Yeah. So we've changed. I mean, we've grown so much as individuals, providers, business owners. I've had the most growth ever within myself, I would say, the last year.
Oh, 100%. So I would want that for other people. So if I could have a billboard out there from just me, I would want other people to find what I found.
Absolutely. Oh, I love it. You guys are so fun. Now, a little preview for our audience. We are going to talk again with Dr. Ashley and Dr. Alli, because they broke free of the conventional medical model. And I want to hear all the dirt. I want to hear all about it. Yeah. So for all of our audience out there, this has been your Healthcare Arsenal podcast. And my hope for you is that with each passing episode, you get closer to being your own best expert. Bye for now.
Thank you.